All right, well, it's 7:30, so I guess we'll get started, and Jem will join us when he's able. I guess I should rename myself so you all know who I am. This is Katie Wright, the director of the VEDS movement, and we are very excited that you're joining us for this International E3 Summit, powered by the Marfan Foundation and the CERN, educating, empowering, and enriching our community. This is also brought to you by the Marfan Foundation's divisions, the Loeys-Dietz Syndrome Foundation and the VEDS movement, and our partners in Europe at the CERN. We'd like to thank our presenting sponsors, Brigham and Women's Hospital and American Communications Construction. And we also want to let you know that the International E3 Summit is a forum to provide an open communication and discussion of issues related to genetic aortic and vascular conditions. Opinions stated in each of these talks are those of the speakers and not necessarily those of the Marfan Foundation or the CERN. We'd really like to thank Dr. Shalhub, and we'll also have Dr. Jem Black with us tonight to share a presentation that Dr. Shalhub prepared and then a live Q&A with both of them. So thank you, Dr. Shalhub, for joining us. Would you like to say hello to everybody before we move on to your presentation? Oh no, I can't hear you, Sherene.
I can fix that. I can unmute myself. Okay. Hello, everybody, and it's nice to see a lot of the virtual faces. I can envision your faces, a lot of you I know, and it's nice to see new people as well. Thank you, Katie, for the introduction. And looks like Dr. Black just joined us as well.
Yes, Dr. Black, would you like to turn on your video and say hello to everybody?
I'm not in a spot for video yet, but let me get there. I can listen though very well. Thanks, everyone.
Okay, great. Thanks for joining us. All right, so now we're going to move on to a presentation from Dr. Shalhub about the management of dissections and aneurysms that she gave in December. And we will move on to plenty of time for Q&A after this presentation. So if you have any questions during the presentation, please put them in the Q&A box in your Whova app. And I'm gonna go ahead and turn off my video now so that we can focus on the presentation.
So over the next half an hour or so, we'll talk about management of dissections and aneurysms and vascular Ehlers-Danlos syndrome. I don't have any financial disclosures, and I have had to borrow some imaging from the web to highlight some of the points that I wanted to showcase to you as I explain some of these principles, and so the images are referenced when applicable. And just as a reminder, this group probably already knows this quite well, that the vascular Ehlers-Danlos syndrome pathology is due to a mutation in type 3 collagen. And type 3 collagen is something that is present in the skin, the arteries and veins, and hollow organs. And so with that, my focus over the next, during this talk, is to really talk about aorta and arteries. So we're going to talk about the things that carry the blood from the heart, the structures. And what I jokingly tell to patients is that I'm a plumber. And so I'm going to introduce you to my world of plumbing, if you will, of vascular surgery. And what I'd like you to walk away with is so that you're fluent in the language that vascular surgeons speak, that you would understand what the differences are between aneurysms and dissections. I will show you which aneurysms and dissections affect the arteries in vascular EDS. And then we'll talk about management principles. I'll give you a primer on what that means. We'll talk about procedures. Catheter embolization, stenting, and open surgical repair. And then I'll go through by location and talk about that. And the idea is that to increase your knowledge base so that you are fluent in this language, and so that when you see your reports or when you look at a CT scan report, or if you're talking to a physician, you're familiar with some of this language as well. So we'll start with basics. What is an aneurysm? So an aneurysm is a dilation of an artery to more than 1.5 times the size of normal. And whenever you say the word aneurysm, it really makes people nervous, predominantly because they think of worst case scenario, which is ruptured aneurysms. But in reality is a lot of aneurysms happen at small sizes. That's, if it's 1.5 times the size of normal, that is very unlikely usually to be associated with risk of rupture. And frequently it's asymptomatic, meaning it's something we have to look for. Unless somebody has a rupture, it's generally not symptomatic. And the way aneurysms present is, can you see my arrow when I move it on the screen?
Yes, we can see it.
Okay. So fusiform aneurysms, this is an example of a fusiform aneurysm. This is an abdominal aortic aneurysm. And the idea is that the aorta, which is the largest artery in the body, is dilated, just like this, as you can see. And that's different than saccular aneurysms, which is more like a berry aneurysm. And so frequently when you think of fusiform aneurysms, we think of abdominal aortic aneurysms. When you think of saccular aneurysms, we think of brain aneurysms. They tend to have a saccular appearance. On the bottom here, here's an example of an iliac artery aneurysm. You can see this person has an iliac artery aneurysm on one side, not the other. The images that are in gray, these are CT scan images. I'm hoping most of you have seen them at one point or the other. But just in terms of orientation, the bone on CT scans always looks white. The air always looks black. And then this grayish color, that's usually the dye that we give to light up the arteries so we can see them. This is another CT scan from the side where we're showing the celiac artery aneurysm, and you can see that the artery is this tubular structure, but then it has this berry-looking aneurysm coming off of it. So that's a celiac artery aneurysm in this case. And again, the reason we care about aneurysms is because we don't want them to rupture, because that's usually associated with bleeding. Now, dissections are different. This is a tear in the wall of the arterial aorta. And what I tell the patients when I see them in clinic is that the liner, the inner lining of the artery or the aorta is sheared off, and then blood can flow between the layers of the walls and separates out this inner layer from the outer layer, from the inside, and you can see blood in between. This is called, and that makes it become a double barrel appearance, so we call that a false lumen and a true lumen. This picture here, these two pictures are what we call intravascular ultrasound. So we put an ultrasound probe on a delivery mechanism. We put it inside the artery or inside the aorta, and we can see the artery from the inside. And you can see this structure here that's flapping. That's the dissection flap. So that came off of this wall here and moved to the middle. So that's what a dissection looks like. Right here is a CT scan looking at somebody's aorta in their chest, and you can the heart is down here, coming up the ascending aorta arch and then descending aorta. So when we talk about descending aortic dissections, this is what that looks like, and that's called a type B aortic dissection. But we can have dissections in other places, like here's a celiac artery dissection, here's an external iliac artery dissection. So it looks different than an aneurysm. Now, the other important principle to know is that you can have both aneurysms and dissections in the same person. This is an example. This is not a vascular EDS patient. This is a patient with Marfan syndrome, in fact. But you can see that this person has an aortic root aneurysm and then has a dissection in the descending thoracic aorta, which is called a type B aortic dissection, in an aorta that is normal in size. So you can have aneurysms and dissections in the same person. You can have aneurysms that go on and dissect. You can have dissections that over time can become an aneurysm where the weak wall starts bulging out. So they're not mutually exclusive categories, and this is where language, being precise in one's language, is important. So what happens in vascular Ehlers-Danlos syndrome in people who start having aneurysms and dissections? Well, what we found, and this is what's challenging about studying this, is that people can have multiple aneurysms and or dissections everywhere in the arterial tree. So anywhere you have arteries, you can potentially have this. The image on the left is from a 2005 paper from the Mayo Clinic where they looked at 24 patients with vascular EDS, and they had 132 what they called complications, but what they meant was aneurysms and dissections. And you can see the distribution across the anatomy, and this is really a classic picture, and it really drives the point home. On the right is what we found in 53 patients. This is a paper that we just published recently, actually. November 2019 came out in print. And we had 53 patients from multiple centers and had 138 aortic arterial pathologies, and basically showed that the distribution is fairly similar. In yellow, I'm showing the aortas because this is important. When we think of heritable aortopathies, we do talk about vascular EDS, but it is also important to remember that vascular EDS tends to manifest more with arterial pathology more frequently than aortic pathology, although you can get both. And in the middle here, you see hepatic, celiac, splenic, and SMA and IMA. All these are mesenteric arteries. These are the arteries that are involved with the spleen, liver, and intestines, and they can be involved. And the other thing is the iliac arteries right here. What I tell people is the inverted Y. That area is about 40% of the patients will have pathology there. In that same study, we also asked the questions like, well, what were the interventions? How often did people need any surgery or interventions? And you can see here on the bottom axis here, I put in the locations. You have carotids, coronaries, mesenterics, renal, aorta, and iliac arteries. And in the gold color, you can see these are people who were managed non-operatively, medical management, meaning they did not need surgery. And in blue are the endovascular interventions. And endo, in most cases, was something called embolization. And I'll talk a little bit more about that as well. And then less frequently, you'll see open operations. And most of these open operations happen in people who needed aortic surgery and a little bit in iliac artery surgery. And so what do we know? We do know that when we have an established preoperative diagnosis and when somebody is treated in an elective setting, when it's not an emergency, the outcomes are substantially better. And it absolutely makes sense from a vascular surgery perspective. We do know that whenever we operate for ruptures, the outcomes tend to be worse than if we operate in a controlled elective type setting. And certainly when we do know the diagnosis ahead of time, we can modify our techniques to account for the fragility in the tissue and be prepared even mentally going into the OR. And in vascular surgery, we usually say that 90% of the case happens before you step foot in the OR. It really, a lot of it is about planning and making, having a game plan for how you're going to approach this. So here are some principles. Repair, if we're going to repair the arteries, usually it's indicated by the size of the aneurysm or complications of dissection. Those are the things that make us say we need to operate and do something about an aneurysm or a dissection. So for example, and I'll talk a little bit more about aneurysm sizes, but size of aneurysm in general tends to correlate with risk of rupture. And we can talk a little bit more later in the Q&A section about like how do we decide what that is in vasculitis. And then complications of dissection, meaning the dissection has now converted into an aneurysm because the wall is weak, or there is bleeding, or the dissection flap is blocking off blood flow somehow. The other principle is that the risk of surgery or the benefit of surgery has to be much, much better than the risk of surgery. So the risk of aneurysm rupture or complications has to outweigh the risk of surgery. Otherwise, what's the point of surgery, right? So we have to make sure that we can do this and it's worthwhile. And then the management approach, whether it's medical or surgical, so we manage patients both medically and surgically, the management approach does vary by the type of the pathology, the aneurysm or dissection, and where it's located in the body, which part of the aorta, which arterial tree is involved. That determines how we're going to approach it. So with that, we're going to talk about aortic and arterial pathology management. This is the primer. So when do aneurysms rupture? So every location on the body has different thresholds for when we think there is a risk of rupture, but the most extensively studied aneurysm is the abdominal aortic aneurysm. And population studies, this is everybody, not vasculitis specifically, but everybody, all comers, the risk of rupture is somewhere between 5 to 5.9 centimeters, and that becomes 3 to 15% annually is the risk of rupture. And at that point, the benefit of repair far outweighs there's definitely clear benefit for repair, so the risk of repair is much less than the risk of rupture, and in that circumstance, we do recommend repair. Now, we do know that some people, you can see here, less than 4 centimeters, the risk of rupture was 0 in population studies, and between 4 to 4.9 centimeters, it was around 0.5 to 5% risk. So there is a risk of rupture at smaller aneurysm sizes, but definitely when they're very small, we usually don't repair those. And remember I said aneurysms is 1.5 times the normal size. Aortas are on average in a average size guy is around 2 centimeters, maybe a little bit smaller for women. And so you can see that even at double the size of what we consider normal, the risk of rupture is nil. The picture here on the right is a picture of somebody who has vascular EDS and had an abdominal aortic aneurysm rupture. And what I wanted to show here is that unlike this picture down on the bottom that shows what we call an atherosclerotic aneurysm, people who have vascular EDS can also have dissections with the aneurysm itself. So remember, aneurysms and dissections can coexist. The other principles to tell you is endovascular techniques. So we're going to talk about how we modify, or what does it mean to have endovascular surgery, and then here are the principles. So the golden rule is that we avoid diagnostic angiograms. We don't want to do invasive testing if we don't need to do invasive testing, and we try to use non-invasive modalities to diagnose these aneurysms and dissections, such as ultrasound or CT scan or MRI. So we want to avoid invasive arterial testing if we don't have to do it. Embolization, I'll talk a little bit more what that means, but we prefer to embolize branch arteries when we can. And if we need to stent medium-sized arteries, then we will do that. And then in general, we want to avoid the stent grafts in the aorta. So stent grafts are okay in medium-sized arteries, but they seem to have higher risk in the aorta. And I'll recircle back to those. So endovascular repair, what does that mean? That means we're using wires and catheters to repair arteries. And the way we get to them is via the femoral artery usually. It's usually done in an angiography suite or done in a hybrid room. So this is an example of how we've evolved over time. When I was in training, we used these portable machines up here in the picture on the upper right. And now here's my OR with all this equipment, and that's how we have a hybrid room, which is fully dedicated to doing this, to treating people with endovascular means. So here's embolization or catheter embolization, and this is a really nice picture that I borrowed from this website. But basically the idea, again, of endovascular approaches is that you're going in from a site away from wherever it is that you're treating, and you snake these wires and catheters up, and then you do things to the artery, whether it's stenting or embolization. And so embolization in a nutshell is that you are cutting off the blood flow into that aneurysm. Usually saccular aneurysms are great for this kind of approach. Or if it's a branch artery that you don't need. If there's redundancy in the system or collaterals and you can sacrifice that artery, then that's also an artery that's appropriate for embolization. Vascular surgeons can do this, but also interventional radiologists. So depending on where somebody lives, it either could be a vascular surgeon or an interventional radiologist. And again, this is the picture for this person having a saccular aneurysm in the brain, which is commonly where you see this technique used. And again, they get the catheter and the wire in there and then put in the coiled wire to basically take this aneurysm out of commission, so it's out of the circulation now. What about arterial stents? They come in a couple of varieties. There's bare metal stents and then there's covered stents, and again, I borrowed these pictures to show you. So bare metal stents were invented for arteries that are too narrow. And so what I tell people in vascular surgery, if the artery is too narrow, you make it bigger. If it's too big, you make it smaller, i.e. aneurysm, you make it smaller. And if you can't, you go around them, so bypasses. And so this was originally designed for small arteries. And there's really not much role, in my opinion, for vascular EDS. Maybe there's some exceptions. But in general, what we're thinking about is covered stents, but because we're trying to isolate these aneurysms from the circulation. And so it's basically like putting in a liner in the arteries. And remember I said these are good for medium-sized arteries. But we have to be mindful that the arteries, again, even when we're going through the femoral artery, these arteries are fragile. And so people can have bleeding and can have pseudoaneurysm. Pseudoaneurysm is a false aneurysm, meaning it's really bleeding, but it's contained by the tissue around the artery, and that's why it's called a pseudoaneurysm. And so because of that concern, this is a very nice paper published by Dr. Jim Black back in 2012, where they reviewed their approach for everybody with EDS, not just vascular EDS, but in general. And he proposed that we do what we call old-fashioned cut-downs, where we actually make an incision, get the artery out, and then we repair them. These little rectangles here, these are called pledgets, and the idea is that you put in a pledget so that the suture, which is very fine suture, the suture itself wouldn't cut through the artery, and you're able to close the artery in a very controlled manner. And then we wrap the artery on top of that to give it more support. And I think this is a great, I've used this technique and it works really well, and it eliminates a lot of the stress of wondering if somebody's going to have bleeding afterwards. That said, we've also, in our case series, when we reviewed people, there are quite a few people who've had angiographic, whether it's diagnostic or procedures, that were done in the setting where the diagnosis was not known, so they were managed like anybody else with compression, and they seem to do okay with that. So we really don't know for sure who will or will not have a complication, but to be on the safe side, open exposure and repair, just like shown here, is what I would recommend. I do want to take a few minutes to talk about aortic stent grafts. I already told you that I do not think this is a good idea, and I'll show you why, but you need to be aware of them. So these are stent grafts. Again, they're liners that go inside the aorta. You can see a picture here of me holding the delivery mechanism. It's the thickness of a big pencil or a pen, so quite long, and then the stent graft is on the top right here over my hand. We go into the artery, and this video shows you here, again, this is an aneurysm. So again, these were designed for people with thoracic aneurysms in this case. And this is the delivery mechanism. And then you unsheath it and put the liner in, and that excludes the aneurysm from the circulation. And this is a picture of somebody who had aneurysms for other reasons, and they had a stent graft. So it's very attractive as a minimally invasive option compared to open surgery. And in fact, here's a picture of somebody who came in with a ruptured type B aortic dissection. Was quite sick at the time, and we put in a stent graft, and you can see within 30 days the aorta healed. We don't have any data on this in vascular EDS, and I'll comment a little bit more on why we think this is not a good option for people with vascular EDS. This is the counterpart to this. This is the abdominal aortic endovascular repair, and they're designed again in what we call a bifurcated graft, like an inverted Y, to accommodate the iliac arteries, as you can see here. And this is an example of somebody who actually was haploinsufficient for vascular EDS, so they have normal collagen but reduced amount, half the amount, and this person's in their 60s. Had a sibling who had also an EVAR, endovascular repair, before the diagnosis was known, and has done quite well post that repair. So there are some exceptions, but these are really the exceptions. So what do we know? We do know that pivotal studies, so these are the research studies that looked at stent grafts, aortic stent grafts, excluded people who have connective tissue disorders, predominantly because there were concerns that the device will not fixate in the tissue that is brittle, and that the aorta will continue to basically degenerate or continue to become an aneurysm around there. And there was concern that the device won't sit in place. And this is a case report, not with vascular EDS, but somebody who had connective tissue disorder. And you can see this bulge up top, and this is the tear in the aorta itself. We asked the same question, and we used the GenTAC data. Some of you may be familiar with GenTAC. And thankfully, there weren't many patients in that cohort that had the stent grafts, and we had only 12 that had an acute dissection that needed a stent graft, and 3 of these folks had what we call retrograde dissection. So what that means is that when the graft is in place, the aorta tears, in the front end because of the graft being in place. So this retrograde dissection is a high-risk complication, and it's a dreaded complication. And so that's one of the reasons why we avoid using stent grafts in the thoracic aorta. Well, what about in the abdominal aorta? Really not much is written about it in terms of vascular EDS specifically, but we do know that in people with family history of abdominal aortic aneurysms, they tend to have higher 30-day mortality and higher complications after endovascular repair. So that's worth noting. So what does that leave us? Well, it leaves us with open surgical techniques. This is old-fashioned surgery. It's been around since the 50s. The principles really that we modify is that we do use gentle retraction. So you can see this is an example of one of the retractors we would use, and these are all metal. And so the idea is that, again, we want to be very gentle in how we move the bowels out of the way. We want to be very gentle in how we put these retractors in place. Pledgeted repair, so instead of just using sutures like this, which is the principle of how we would fix an aorta, we would use the pledgets like I showed you earlier. And then the clamps, we would use gentle clamps and padded clamps. The other thing is we definitely talk to people about risk factor modification. No matter what we do surgically, you still have to modify around the lifestyle, and so that includes quitting smoking. If there's any hypertension, we want to treat that. Daily walking and moderate exercise, and obviously the screening program where we're looking for these aneurysms and dissections. In terms of medical management, we've had a discussion about this at our last session where we talked about beta blockers versus angiotensin receptor blockers. The low-dose aspirin, that is a standard recommendation for anybody with aneurysms and dissections, and certainly can be this particular recommendation can be tailored to the patient themselves. And obviously, we remind people to avoid fluoroquinolones just because it's been reported to be associated with higher risk of aneurysms and dissections. There's also the concept of permissive hypotension. So what that means is that if somebody has a rupture, we do not want to drive their blood pressure to high or normal levels. And in fact, if there is a rupture, we want to allow them to be permissively hypotensive, meaning it's okay if their blood pressure is lower as long as they're mentating, because we don't want to volume overload them. And this principle is quite relevant to vascular EDS. In some of the earlier reports or earlier studies, they've shown that when people are in the hospital, there seems to be more and more events that happen while they're in the hospital, and it was thought maybe it's related to the fluid overload. And while that has not been specifically studied in vascular EDS, we do know that patients with ruptured aortic, abdominal aortic aneurysms, in fact, do better if we allow them to be permissively hypotensive. And so the principle still applies. So as this is our last section here, we're going to talk about bilocation. So how do we think about these by location now? Carotid cavernous fistulas is not something I treat. This is something neurointerventionalists usually treat, but it is the abnormal communication between the carotid artery and cavernous sinus. So this is the intracranial carotid artery up in the behind the eye, and you can see this is a nice illustration from this article. And these are very suitable for endovascular coil embolization. These are the coils that you can see here in an embolization in somebody who had one of these carotid cavernous fistulas. Well, what about extracranial carotid and vertebral artery dissections? So the majority of them are really pseudoaneurysms. And what I mean by that is that they're usually in association with dissection, and then the weaker wall bulges out and becomes an aneurysm, which is why technically they're pseudoaneurysms. This is a picture of carotid arteries. And these extracranial carotid arteries, there's a common carotid artery, and then it divides up into an internal and an external. And here's a picture of the vertebral artery. So in the back of the neck, it runs between the vertebral bodies. In my experience, most people with vascular EDS have, this arrow is not quite lined up, but they have their aneurysms and dissections. If they're going to have them in the vertebral arteries, they tend to be at the skull base, and they tend to be small. And usually they'll say they have headaches or neck spasm around that area, and when we look, we'll find them. This here is a book, Carotid and Vertebral Artery Dissection, a guide for survivors and their loved ones. I do recommend it if somebody has had carotid artery dissection or aneurysms to read that. It's quite well written, and it's written in lay term for everybody to understand. But the majority of these we treat medically, not surgically. And in fact, there's been a study, this is a randomized trial, not in vascular EDS, but in general. They took 250 patients, 118 carotid dissections and 132 vertebral dissections, and they randomized them between 2006 to 2013 into two groups. One group received antiplatelet therapy, that's aspirin, and the other group received anticoagulation, that's heparin, and then Coumadin, so basically thinning their blood even more. And the idea is the concern for them having a stroke following their dissection and aneurysm. And in fact, what this study had showed at 1 year follow-up is that the stroke or death risk seemed to be similar between the two groups. It was 2% in the group with the antiplatelet therapy and 1% in the group with anticoagulation. And we do know that surgery in these circumstances has poor outcomes, so really the keystone management here is medical therapy, and now we have data to suggest that aspirin is just as good as anticoagulation in this circumstance. Now, there's an exception to what I mentioned, which is the extracranial carotid artery aneurysms. These are the true aneurysms. These are exceedingly rare, and in fact, they account for about 1% of all peripheral artery aneurysms, so very rare. And this is one case of somebody who had vascular EDS, was cared for at Hopkins, who had a large 6-centimeter carotid artery aneurysm after delivering her child and required embolization. So this is how she was managed. Now, this was a safer option than an open operation just because of the location of where it's present, and it was the equivalent of basically ligating or tying off the artery. She did have a stroke, but then it recovered from the stroke, so it was a high-risk location, but this is an exception to the medical management that I just mentioned. Well, what about subclavian arteries? These are the arteries right here up on the top of the chest going into the arm, so this is in green, you can see them here. And so a couple of things, they can present with aneurysms and or ruptures. This is a young person who is 18 who had subclavian artery rupture. The diagnosis was already established ahead of time. The surgeons in this group wrote up the case report, and you can see the rupture here where blood was not only going out into the base of the neck, but also into the vein as well. And this person was treated with carotid artery stenting and subclavian artery stenting and did quite well with that. This is an example of somebody with a big subclavian artery aneurysm, and in this circumstance we had to do what we call a hybrid operation, where I did a bypass of the artery itself and then put a bunch of coils in the artery to take it out of commission. Well, what about celiac artery dissections? This is a picture of the celiac artery off the aorta, so this is the first branch going into the abdomen, and this one is the branch that's in charge of feeding the hepatic artery, the splenic artery, and the stomach area. So people can have dissections, not unusual to see that, and can have small aneurysms there. And in general, these tend to be managed medically. Here's two examples of other mesenteric arteries. The splenic artery is one of these arteries that is redundant in the body, and so we feel safe embolizing it, meaning taking it out of commission and putting a bunch of coils in there, because the spleen is also supplied by other arteries that come through this system, and so that is one option for the splenic artery. But the hepatic artery in this circumstance is not something we can take out, and so in this case we use a stent graft, a covered stent, across it to isolate the aneurysm and still keep flow to the liver. The superior mesenteric artery, this is the main artery that feeds the intestines, and again, most circumstances and recommendations are for medical therapy. And in fact, what was interesting is we did a study where we did retrospective review of 222 cases, and again, this is relatively rare, so this was a consortium that reviewed this together. And in fact, they showed that medical therapy and intervention did not improve the uncomplicated version, meaning if there were no symptoms, they didn't even feel that medical therapy made a difference. So in general, we control blood pressure plus minus aspirin, and certainly if they're having symptoms, we can then upgrade to blood thinners, and if still having symptoms, then we would recommend surgery at that point. Common iliac artery aneurysms, remember I said 40% of people with vascular EDS in that cohort that we reviewed had some form of aneurysm or dissection in the iliac artery. So this is an example of a 42-year-old woman. You can see the iliac artery aneurysms here. This is, again, the 65-year-old man that I mentioned earlier that had the endovascular repair of the aneurysm. And then this is a picture of somebody who was treated at Hopkins and needed an open operation, which is appropriate for the type of mutation that they had. External iliac arteries. So for anatomy orientation, this is the aorta coming into the abdomen. Here's the common iliac arteries. And then this is the external iliac artery here. So that where I showed you the aneurysms was higher up. As you go down, it's the external iliac artery. People can have dissections. This is the tear, as I mentioned, and can block off the artery. And in this case, this person had a stent, but also needed a bypass operation to repair that. I'm going to finish with the retroperitoneal, just a comment on retroperitoneal bleeds. These are these spontaneous bleedings around the psoas muscle, so in the back, and can occur because of dissections or can occur because small branches are bleeding. And again, the principles is permissive hypotension, judicious transfusions, and then if somebody's on blood thinners, we reverse the blood thinners, and then potentially if they need an angiogram with embolization, then we would recommend that. So in closing, most aneurysms and dissections can be managed non-operatively, i.e. medically. Elective repairs have better outcomes than repairs in the emergency setting. Knowing the diagnosis does improve the outcome because we're prepared. And when intervention is needed for an enlarging artery aneurysm or rupture, we really need to look at embolization and or stenting, and they seem to be well tolerated, and I've shown you how by different locations that approach can change. And then open repair of ruptured abdominal aortic aneurysms seem to also be tolerated, even though it's open repair, and they seem to have similar outcomes to patients without vascular EDS. So this was based on the paper that we published in 2019, where we have multiple patients have had ruptured open repairs. And then the role of endovascular aortic stent graft still remains to be defined. It's not, the key to learning about this is people who potentially had the stent grafts without knowing their diagnosis, and to see if really that does work. And again, the way I would approach this is I tailor this to each individual patient.
Great. Thank you, Sherene, for preparing that presentation. Before we continue, I would like to rescue Jim Black from the attendee box so he can join us. All right. So Sherene, I know there's a couple more slides that you wanted to present on current things you're working on.
Thank you, Katie. And this is just for people who may not be familiar with this. We do have a natural history study where we are enrolling anybody who has a genetically confirmed vascular Ehlers-Danlos syndrome diagnosis. We need to have the genetic testing, confirming this diagnosis, or skin biopsy, and of any age, anywhere in the United States and globally. So if you're interested in this, please feel free to reach out to us. The information is here, and Katie has that information as well. To date, we have about 180 people that have enrolled from around the world, and we're very excited that this has happened, and we have been collecting their records. And shortly we're going to come out with our first data, analysis using this information. And just think about it from the perspective of the more we learn, the more, we can tailor our therapies and bring back the information to the community and help guide our therapy. So this was one study. The other study, if you don't mind, Katie, putting that up, is a study where we're looking to evaluate the impact of COVID-19 on people with aortic dissections and people at risk for aortic dissections. So definitely people who have vascular EDS are considered people at risk for aortic dissections. COVID-19, unfortunately, has, altered all our lives in a dramatic way. And so we are very interested in understanding how this has affected your healthcare. So this is a survey, and that's the information there as well. And it takes about 10 to 15 minutes to fill that out. And we'd appreciate hearing your voices as well. Thank you, Katie.
Thank you, Sherene. And now we're actually going to share the live Q&A screen so that Dr. Black and Dr. Shalhub can read it. Let's see if I can find it here. Sorry about that. Give us just a moment. We will find this.
Well, while you're working on that, just for the audience, you've heard me refer to Jim Black many times in my talks. So it's actually nice that we're both in the same setting. He was one of the early surgeons that I reached out to when I finished training. I said, hey, I'm interested in taking care of people with vascular EDS. So it's a pleasure to see him here and for us to do this together.
Yeah, it's a great team we have together. And working with the foundations at BenX were great too.
So I do have the Q&A screen up. Are you able to see it?
Yes, we can see it. Do you want to read the questions, Katie, and then Jim and I will take turns answering?
That sounds great. And actually, I do want to start with a question that was given in one of our other talks today in the ABCs of VEDS that we didn't get to. Someone asked, I'm assuming they're newly diagnosed, but they asked earlier, they're going to see their vascular surgeon for the first time. What would you recommend for someone with VEDS seeing a vascular surgeon for the first time?
Katie, that's a really great question. And we've had multiple people say that, because I do advise that people establish care with a vascular surgeon locally, so that it's at least somebody who knows them. We've also had questions along the lines of like, well, if they're not doing anything, why are they coming to see us? And so sometimes people get that question as well. And you have stories to share in that, Jeff. But basically, my goal is that I think it's nice to have somebody locally that that a vascular surgeon is familiar with you, and that if there is an emergency, they can either help guide the therapy during that time, or themselves, if they're on call, they can help with that. Certainly, if it's, at least in our system, not everybody takes call every night, and I would say that's probably general for everybody, and so there's a call schedule. But still, it is nice to have an identified surgeon who knows the person. And I do ask people, to talk about all these things that we talked about today, the medications or lifestyle modifications, the surveillance plan, and so on. Jim, what do you tell people when they establish care with a vascular surgeon around the country?
Yeah, I think that there's a very good chance that a well-informed patient might very well know more about their disorder than a reasonably mature vascular surgeon or cardiac surgeon. And so I think, establishing that relationship so they understand a little bit about the vascular EDS condition and some of the issues that can come up, I think is useful. Ultimately, having a coordination at least up to a university center where someone is eminently more familiar with vascular EDS is also good, because between the local person and the university experts, they can sort of help back up each other in an emergency. So I think that that's a useful relationship to establish between the community surgeons who might be close by and the university surgeons who might be hundreds of miles away.
Thank you. And of course, this is also new for somebody who's just diagnosed, so it's really helpful to have both of you here to answer these kinds of questions. Sherene, I think, or Dr. Shalhub, I think you did ask this question or answer this question in your talk about the best procedure for an aneurysm in the iliac artery that has ruptured, or is that a size where intervention is recommended? Would that best procedure be a stent, embolization, and then, you know, I think you did talk about the carotid and vertebral arteries as well.
Right, and I think this is a great question because it highlights how we have to tailor the therapy to the presentation that we're seeing and to the location. So for example, and I mentioned that earlier, for external iliac artery dissections, if there is a rupture, that is an area that's amenable to stenting, and same thing with the common iliac artery. But if it's in the internal iliac artery, for example, that's a place where we feel comfortable again putting in coils, for example, because it's feeding the pelvis but not the leg, so we can coil it and then stent the iliac artery, the external iliac artery, the common iliac artery. Aneurysms in the carotid and vertebral arteries in general are managed medically. Unless there's a large aneurysm, and I showed that case that Dr. Black did a few years ago with the large carotid artery aneurysm where they used the coil embolization. And maybe Jim, you can comment a little bit on that because that's not, that's obviously a high risk procedure in a high risk patient. So maybe you can give some insight into your thought process at that time.
Sure, I think that there's always a concern in vascular ES of the balance of tissue fragility and vascular fragility, but sometimes it's not just the approach to it's not just the vessel that we have to contend with, it's also the surrounding structures. And so again, having a surgeon who has experience in this regard is really important because it's sometimes weighing some of those things which are soft calls, as they say. There's no easy metric to identify who's going to do well with their traditional type of surgery versus an endovascular procedure, but we certainly know that there are some anatomic or some anatomy approaches that are just going to be inherently very destructive. And so we want to minimize the trauma of surgery to every possible degree. And if an endovascular approach is going to give a good outcome or an expectation of a good outcome, I should say, then that's almost always going to be the right choice, particularly for a situation where I think I saw a little farther down of someone with a iliac rupture where the anatomy is going to be changed by the nature of the vascular rupture, and there will be more surgical trauma to deal with the vessel. So again, a stent would be probably a better solution in a rupture circumstance, 9 out of 10 times. But that again, it goes to the balance of the patient and the surgeon and what can be accomplished in the particular healthcare environment they're in that emergency.
Thank you. Thank you both for your perspectives on that. And I love that you cover the differences in all of the arteries and how it's very tailored to specific situations. So this one's a little complicated. So 48 years old with VEDS, 14 years post-aortic aneurysm repair, and had an aortic valve replaced with a metal valve. The valve is now in moderate or severe mode for function, maybe some scar tissue. I'm not 100% sure what the question is, but I think they're looking for potentially if they meet a new surgeon for this issue, what should they be looking out for?
Yes, this is a situation that's not uncommon. When a valve is replaced, sometimes it can develop the valve leaflets can develop some stickiness. If the valve is preserved, sometimes the aortic valve can degenerate in the 10 to 15-year window after surgery. So I think, this is a situation where there could be a reasonable option for considering what's called a transcatheter valve replacement. That's a very complex procedure performed by cardiologists and cardiac surgeons. So I think an evaluation along the lines with what we call a cardiac structural team, that's usually a team of a cardiologist and a cardiac surgeon could get at this question.
Okay.
And I would say somebody in what we call a tertiary care center, so a center that does a lot of these cases with multiple specialties that are available. And again, it's going back to what we were talking about earlier, that you will have a higher level of expertise, not only with the actual procedure, but also with knowledge about vascular EDS versus, it's just you have to ask the questions like, what is the level of expertise in the center where you're being seen?
Thank you. And hopefully that answered the question. If it didn't, feel free to submit it to our Help and Resource Center, and we will go further in depth with that question. The next question is, what age should I start worrying about aneurysms and dissections in VEDS?
So that we have good natural history study. This is from Dr. Peter Byers' work that he's done over the years, and where he's shown that you can start seeing aneurysms and dissections in the 20s, but mostly by the time somebody's in their 40s, you will start seeing aneurysms and dissections. That said, I also have patients in their 60s who have not had any aneurysms and dissections yet. So there's a wide degree of variability, and it is dependent on the type of the underlying pathogenic variant that's in the COL3A1 gene. So people, for example, who have the null mutation, or also known as the haploinsufficiency mutation, tend to have a more milder, quote unquote, phenotype, meaning the way the disease presents. So they tend to be older when they start having aneurysms and dissections compared to, for example, people who have, let's say, large amino acid substitutions in the glycine substitutions. They tend to manifest with earlier disease manifestation. So it is variable. But in general, when we talk about screening, it is not unreasonable to start in their 20s.
Thank you. I will go ahead and mark that as answered. So for someone who is 57 and has VEDS, has had a stroke and multiple compartment syndrome occurrences, I guess the first acute and lower left leg was not diagnosed for 2 months, which resulted in extreme spasms, resulting in left foot and ankle freezing and a severe pointed toe spasm. They have to wear a minimal 3-inch heeled boot in order to walk. Can you recommend a knowledgeable professional to help? I would say first, we do have a list of institutions at the VEDS movement, and you can always ask our Help and Resource Center for help finding a professional. But if Dr. Shalhub and Dr. Black, if you know anybody, I think we need to know more about where they are specifically, right?
Yeah, I think this is obviously a unique clinical problem. It's not one that we see generally across the board in patients with vascular EDS. Sort of reading between the lines here, it sounds as though there might be some nerve damage related to some of these compartment syndrome occurrences. Again, not a very common manifestation of vascular EDS, so I think probably working through the foundation to look for someone locally along the lines of an orthopedic surgeon would probably be where one would have to start.
Okay, thank you for your help with that one. Okay, so as my stroke at age 22 in 1985 was a dissection of the carotid artery, resulting in left side paralysis. No surgery was performed, and I'm allergic to contrast. What is the best follow-up to check the status of that dissection?
Allergy to contrast, there's a couple studies that require contrast. One is a CT scan, which we use iodinated contrast, and then you also have MR angiograms, which use gadolinium contrast. So depending on which contrast you're allergic to, that would dictate which other study could be done. Either studies are fine, a CT angiogram or an MR angiogram. The other modality that doesn't require any contrast is using a duplex ultrasound, but that's really only good to look at the carotid arteries in the neck. Once you get to the skull base and higher, sometimes it's harder to see. And certainly something in the skull is not something that we can see in very good detail using the ultrasound. We can see flow, but we can't see the details of the arteries.
Thank you. Okay. So are there any precautions a patient should advocate for during endovascular catheterization, given our propensity for tortuous vessels?
I think that this is not uncommon, particularly when you start thinking about endovascular procedures for splenic artery aneurysms, which generally are tortuous and vascular EDS. So I don't think the tortuosity is unique to how any endovascular interventionalist would be planning their procedure. That's generally something that's very obvious The areas that I often comment are worrisome just to even simply catheterize and cross are vessels like the iliac vessels and the celiac artery, which is on the way to the splenic artery. And so, perhaps mentioning that that you have heard in a blind sense or anonymity that I'm saying it, you could say, well, I've read that the iliac arteries and celiac arteries are at risk for dissection just with catheter manipulation. And I think, some of those reminders are appropriate if a patient is concerned, but tortuosity is going to be part of the intervention equation that the surgeon would be talking with you about proceeding with that procedure.
Okay. Thank you. Dr. Shalhub, do you have anything to add for that one, or are we good?
No, I think we're good. We can go to the next one.
Okay. So the next question is, what are the risks associated with stents for carotid artery dissections? Prior to my diagnosis, I dissected both sides and received emergency stent placement in both.
So stents in the carotid arteries in general tend to do very well, even in people who have vasculitis. And depending on where the stents were placed, frequently what I've seen is that they're usually at the skull base. And again, they seem to do very well. And we follow those usually with a CT scan. Depending on who put the stent in, sometimes the neurointerventionalist will repeat the angiograms, which are diagnostic angiograms. So we tend to have conversations about whether or not we want to proceed with a diagnostic angiogram, meaning going in through the arteries for the risks that we were just talking about, versus getting an MR scan or a CT scan to follow those. But I would say in general, they do well, and we just have to follow them over time.
Okay. And the next question is, at what size would you intervene on an iliac artery aneurysm? I think this was in your presentation, but could you go over that again?
Sure, I missed part of the presentation because I was having trouble with the connection, so I'll let Sherene handle that.
I'm sorry.
So I did not give a size. What I did say is that we follow them. So in general, again, for the average population, we talk about around 3.5 centimeters is the number that we think about for iliac artery aneurysms to say that this is the time to think about repair. The other approach, so the way I think about these aneurysms, if this is the first time we're meeting and it's less than 3.5 centimeters, then we do a surveillance plan where I bring people back in 6 months and we see if this aneurysm is growing or if it's staying stable in size. Certainly, if it is growing more than 0.5 centimeter in 6 months, that's something we call rapid growing, and in that circumstance, we have a discussion about repairs. Always, whenever you have a discussion with a vascular surgeon, the question is, what do you normally do for everybody? And then that's a good starting point for the discussion. And then you backtrack and say, okay, how do we modify our approach to accommodate somebody who has vasculitis? I still think 3 to 3.5 centimeter is a reasonable number, and I have not treated much smaller ones unless they seem to be growing. Jem, do you have a different approach, or how do you approach iliac artery aneurysms?
I think 3 centimeters is reasonable. I think one of the things I am concerned about is when someone has a pre-existent aneurysm, maybe it's sitting around 2.5 centimeters, and all of a sudden then on a surveillance image, we now appreciate that same aneurysm, although not bigger, now has a new dissection present inside that pre-existent aneurysm. And I think that's a situation that I would repair, 10 out of 10 times. I think a dissection within a pre-existing aneurysm, even if the aneurysm is below our threshold for repair, is one that should not be considered stable and should probably be fixed.
Right, and that goes back to the whole changing, right? It's changing its behavior.
Right.
So I think the next question is something that a lot of people in the community have experienced or wondered, and why don't, and let me rephrase this question. So I think depending on what hospital you go to, you may receive a different, obviously you have different surgeons. So do all hospitals and surgeons use the same surgical techniques? And would they be able to accommodate somebody with a VEDS diagnosis, for example, with padded clamps?
I think that there's plus sides and minus sides about this, and you know, some of the techniques that we do for patients with vascular EDS are not easily translatable to other hospitals, in the sense that, for example, we know most of our patients with VDS are younger, and so we might choose to induce a very low blood pressure that would not otherwise be comfortable for someone who's my age, 50 or older. So padded clamps also are a little bit bulky, and so if you have a surgical exposure that's a little bit narrowed or difficult, a padded clamp means you have to make more exposure, therefore more surgical trauma, to get that clamp in a position to be used. I think generally speaking, there are things we do to try and make surgery safer across the board. There are things that we have to do that are unique for vascular EDS to make that type of surgery safe, and those things are slightly different.
And would there be any benefit for doing those things for somebody without a VEDS diagnosis?
Without a VEDS diagnosis, standard surgical care, standard surgical handling are usually well tolerated. So,
okay.
You know, getting down into the weeds about technique is probably something that's going to cloud what should be otherwise routine surgery.
Okay, thank you. For someone who received a T-bar stent for a type B dissection before they were diagnosed with VEDS, would you recommend doing anything about that now that they know that they have VEDS?
The way I would approach this is it would be important to know the kind of mutation that we're talking about. Again, is this a haploinsufficiency, for example, or another kind? Because that helps guide, you know, what we would expect the stent graft to do. And also it's important to know what kind of stent graft is in place. So understanding the technical components of what went on, you know, with that surgery. I would say at this point, follow up over time, because remember, when we talk about the risks, you know, people who had known diagnoses were intentionally excluded from the studies. So because of the concern for the fragile tissue, that said, there are people who've had these stent grafts placed, and I mentioned that in the talk, before their diagnosis was known. And that in and of itself has also been educational for us to understand how the aorta is behaving. I would say at this point, if you're doing well, we'll continue to monitor and see how the aorta is behaving around that stent graft. If there's any concern that the stent is causing additional problems, then we definitely need to have a conversation about how best to repair that. But I think it's really important to know the type of mutation as well, the type of pathogenic variant. I also want to hear, you know, what Jim thinks about that as well.
Yeah, you know, oftentimes the segment of the aorta that is, you know, along the length of that stent will actually remodel pretty nicely. What we're concerned about here is where the stent is interfacing with the aorta at the top end and the bottom of the stent. And so I think there are certain stents that maybe would do better. I think theoretically there's mechanical information on the stents that maybe some of these stents would be better over time. But of course, when this happens in retrospect, that is, you get your diagnosis after the stent placement, the surgeon doesn't have that information to guide that initial decision. So I've seen a variety of patients with connective tissue disorders who have done well with stents for long periods of time. It just requires the monitoring that Sherene commented is, you know, part and parcel of dissection care. So, you know, an annual CT scan or an MRI to check up on these things.
Thank you. And I think we'll just take one more question. Are both of you taking on new patients for people with VEDS who would like to have a surgery or need a surgery?
Absolutely, and it's nice that there's East Coast and West Coast represented here.
Right, so I think that, you know, we all hope maybe in some form of America in the future, there's a national healthcare system that makes some of these sort of relationships between states less clunky. But we're not there yet. But as best as we can, we try and get as many patients into the door who need surgical care. And if not, we can find other people more locally that might be logistically possible too. Again, that's where the foundation sort of steps in to help you find surgeons who are local to you who can help you.
Thank you. And thank you both for your time tonight. I very much appreciate it. Let me go back to the screen over here. So if we did not get your question answered, please submit it to marfan.org, /E3ask. Where'd it go? There we go. marfan.org/E3ask. We will do our best to get your question answered. Either we can get you connected to a professional, or we can try to get your question answered by one of the experts here today. And just be aware that we are receiving a lot of questions during the E3 Summit, so it might take longer than usual to get to your question, but we will do the best we can to respond to them promptly. If you could complete the session survey in the Whova app, that would let us know how we did tonight. And feel free to use the Whova app to connect with others in the community. There's chat boxes, there's all sorts of cool features in Whova, and we hope to see you in more of our sessions. This is only the first week and the third day, so we're very excited to continue until September 12th. If you want to share your experience on social media, please use the hashtag E3Summit20, and that will let us know that you're chatting about it online. Thank you again, Dr. Shalhub and Dr. Black, for your time tonight, and I know I really appreciate it, and I know that we all do too, so thank you very much.
Good night.
Thank you.
Yeah.
Good night.